KFUG Community Radio. Hey, it is time for this week's Health Matters. Lynn Szabo, are you there?
I am.
It worked. We're doing this over the phone because you had a little occupational thing happen to you, huh?
Yeah, kind of. But I had a possible exposure, so I didn't want to come into the studio. I don't know if Mike's there, but I know we've been pretty open about his recent hospitalization, and I didn't want to make anybody sick. Anyway.
I really appreciate that, Lynn.
Yeah, you are there.
I am. Yeah, no, I'm back, and I appreciate you thinking about that. That means a lot to me.
Yeah.
All right, so today's this week. I've been looking forward. We've been talking about this on the air today and then yesterday as well. But Big Pharma. Where do we begin with this in this week's Health Matters, Lynn Szabo?
I actually wanted to talk about, there's a couple of different things, and this is pretty free-form, but I wanted to start with what the opioid crisis, how it felt in what I call the provider sphere. So how it was specifically in Humboldt and Norte County, like how we got into it and some of the blunders that happened and how we were sweet-talked. And
so you're talking specifically our region, how the opioid crisis has sort of played out here on the North Coast?
Sure.
Wow, interesting. Okay.
Yeah, I was mostly in Humboldt, but also in Del Norte at the time. And I was mostly in the open door system, but also in the Sutter system. And well, the first thing I remember hearing about, the new OxyContin drugs, the long-acting drugs that were put out there by the drug reps and by mostly the Sackler family, was that Open Door had a conference, and all the providers went, even, people who didn't really deal with general medicine, like the peds people and the women's health people. And we just kind of spent maybe 2/3 of a day being indoctrinated. I would say now looking back on it, it was kind of an indoctrination, although none of the providers intended it to be, and I don't think the administration that arranged it attended. But what I remember about it is the first speaker, who was employed by the drug companies, who was a physician. He said sometimes the most appropriate kind of pain control is a bag of frozen peas. And so I think that was kind of a dog whistle to us in a way, to say, okay, I'm going to talk about all this, but, keep in mind there's a lot of other ways to help people with chronic pain issues.
So, Lynn,
that kind of caught my attention.
Let me just ask you, Lynn, because it sounds like you're saying that this person who was making this presentation was doing it on behalf of Purdue Pharma, and at the same time was giving you this as a way of saying, the next thing I'm going to tell you is BS. Is that
it really caught my attention. I don't know that he was speaking for Purdue Pharma because I wasn't, it was a long time ago. But he was definitely speaking about long-acting opioid drugs and why we should be using them over the short-acting hydrocodones.
But doing it with really kind of rolling his eyes as he said it, right?
Right. It felt like a total dog whistle. Really caught my attention. I still remember it. In fact, it's pretty much the one thing of substance I remember from his talk. And I know, I can tell you the vibe in the room with the other providers was, not 100% buy-in, really.
Wow.
So, that was the first thing. And I can tell you they kept talking about how this was such satisfactory pain control, and it was so humane, and how, they talked about the pain scale. They kind of introduced that, and they were trying to get us to do the long-acting stuff instead of giving people 12 Vicodin a day or something like that. Mm-hmm. And they were talking about, the Tylenol toxicity. All of this is stuff we knew. But what we didn't know at the time was that when you give people these drugs, it changes their experience of pain for the rest of their lives. Mm-hmm. So it changes how their brains experience pain, and specifically at the mu receptor sites. And it makes pain harder for them to cope with without narcotics. And this is beyond addiction. This is beyond physiologic or psychologic addiction. It's an actual rearrangement of the structure of how pain is perceived in the brain.
Right.
And I don't know that they didn't know that, but I would be surprised that they didn't know that.
Wow. And so I'm sorry. And this was from when? When was this presentation?
So I was working at Open Door on 10th Street on the mothership, and that was probably like 2005.
Okay. Wow. Oh my God. All right.
Yeah. And so, what did that look like in Del Norte County? Well, Del Norte was, at that time, was the Del Norte Community Health Center was the A Street Clinic, so it was a much smaller thing, and it was more, I think, associated with less about treating pain and more about other parts of family practice.
Mm-hmm.
But what happened is, as a provider, whenever a person was put on these meds, then you would get like all this positive reinforcement from specialists. Let's say somebody had osteoarthritis, had really bad knees, and was waiting for a bilateral knee replacement. And you would get in the consult letter back from the surgeon, this is so great that you put them on these meds because this is going to be super pain control for them through this whole procedure. And not really an understanding that that using these kind of medications was temporary.
Mm-hmm.
So it was looked at as people would be on these the rest of their lives, kind of like they're on blood pressure medicine.
Was there anything different about opiates when they're with the advent of opiates, or opioids? Excuse me, not opiates. Opiates have, of course, been around forever, but opioids. Was there anything different that would make that logical assumption make sense? Like, I don't understand how anybody dealing with opioids could go, oh yeah, maintenance, you're going to be on this the rest of your life, no harm, no foul. It's not like heroin. I can't see that. Were people just so like rose tinted glasses about opioids at the beginning that they didn't understand that, or choosing not to see that?
Well, I think some people were selling it.
Mm-hmm.
Okay, and I think it was kind of like almost like a Pavlovian thing. Provider writes prescription, gets patted on the head by somebody further up the food chain.
Oh my God!
Yeah,
just the amount of disregard you would have to personally undertake in order to do that is just stunning to me. Wow.
And the way it felt, and Joe, family practice person, was like,
hey, that's my family doctor. Watch what you say.
Yeah, but it was like, what?
Wow.
Maybe I should do this, but it doesn't seem right. We're also being told that people in real pain, quote unquote, real pain, would never become physiologically or psychologically addicted to opioids.
What the?
And we would be like,
well, I know better than that.
Yeah, right? Wow. I mean, was that really the expectation? Were these that different a drug that was even a possibility?
I don't think people up here, the people in the trenches actually believed it. I think that was just propaganda, and we kind of, some of us went along with it with a little more enthusiasm, and some of us definitely were reluctant to do that.
Wow.
So Lynn, let me ask you a question. We've heard a lot about how these big pharma companies, have very aggressive sales departments, and in many cases they're whining and dining and all of that kind of thing.
Right.
And I can see that, connected to individual doctors in their own practices. But in a bigger organization, are these, like pharma reps, are they coming to administration and pushing whatever it is they're pushing, whether it's OxyContin or whatever else it may be? And then the administration, then begins to encourage, subtly or not, that the people who are actually practicing medicine use these medications and or techniques, and then when you do that, that's how you get the pat on the head. I mean, does that make sense what I'm asking?
Right. That is totally what was happening. And it was ubiquitous. So I remember that I was sitting next to one of my friends who's a women's health PA, and she's like, why am I here? but all the providers were required to go. Now, I don't know. I know for PAs that we're required to have continuing medical education units on, at the time, on opioid prescribing, but I didn't. That was more specific to my profession, like how PAs work legally, and it was less kind of an advertisement for the medications. So it was a little weird that the entire staff of Open Door was there. It was very required to be there. It was very strange, but there was, to the credit of the providers at Open Door, there was never 100% buy-in, and there were some people that were super resistant, especially on the original Open Door clinic in 10th Street where I was working. My supervising physician, Bob Henriquez, was super resistant to this. So, but you definitely got positive feedback for prescribing.
Wow.
And the other thing too that's kind of part of this is they introduced the pain scale. And that's kind of ubiquitous. Even if you go into clinic, say you're following up your blood pressure, or even you're there with your 7-year-old for a sports physical, oftentimes they will ask where the medical assistants and the nurses are trained to say, where in the pain scale are you today? And they talk about, this is huge in the RN world, pain as the 5th vital sign. And so I will say, as a provider, and my experience with most of the providers is on the family practice level, that was widely ignored. So because patients, so when I was doing walk-in, our 10 on a pain scale was you couldn't crawl out of a burning building to save your life because you were in such agony.
Oh my God, okay.
And we had people all the time tell us they were 15.
Right. Well, and it sounds to me, so two questions I have. So are you saying that this pain scale was basically invented by these people?
Yeah, that's my belief.
And then, of course, it seems to make sense with what you just said, that asking the person in pain how much pain they're in seems to be, in some ways, the most unreliable. Because I was just
self-reporting.
Because I was just in the hospital too, right? And and they were asking me that all the time.
Really, were they the pain scale?
Oh, sure,
okay.
Absolutely. And the first night that this happened to me, I was in a lot of pain, and I was using terms like Lynn just talked about. They're going, what was it on a 1 to 10? I'm going, it was a 12.
Right.
Or then there's this other part where, on the one hand, it's like, well, how much pain are you in now? And so part of me's going, oh, well, I want to play it down. And part of me's going, yeah, but I don't feel good. And, if I'm honest, a shot of Dilaudid would be pretty good right now.
Right.
It seems problematic from a practitioner standpoint.
Yeah, the other thing, too, about the pain scale is there's no universal way to define it, because everybody's experience of pain is different.
Right. It is nothing but subjective.
So, the most pain I've personally been in my life is during labor, and it's like more a contraction at the height is like more than you can stand, and by the time you're thinking, I think I'm going to say something because this is getting like more than I can stand, and then it kind of breaks like a wave on the shore, and you're like, oh, I'm probably okay. But here's what's really insidious: they have pain scales for kids.
Yeah, wow.
Okay, and those are actually more standardized because they have little smiley faces on the 0 end and really, really sad, cryy faces on the 10 end. And so the kids are supposed to point out the face where they are. And that's actually, to me, kind of more standardized because they don't really understand what they're saying, at least the significance of what they're saying. But I do know that pain scales, documenting pain scales, and then also how pain changes. So let's say, Mike, you were at a 12, you got the shot of Dilaudid, and then you went to sleep, but when you woke up, you were at like a 4. So those changes are super documented by the nurses because they're super focused on by, like Medicare.
Right. Because I particularly, that's my only insurance is Medicare. So I'm sure there's a whole lot of regulations related to all of that.
Right. So I think it's largely, I get warning bells go off in my head when somebody comes in. Let's say they were mowing their lawn and they hurt their back and now their sciatica is a little worse, and they'll come in immediately and start talking about a 10 out of 10. And they say it just like that. I'm a 10 out of 10. And I don't actually know very many providers, maybe in the pain field, the specialists pay attention to that, but we don't.
Really?
Yeah. So what I interpret that is, if somebody tells me they're a 10 out of 10, that they're really, really hurting and they probably need help.
Yeah, okay.
But not necessarily the lauded help.
Right.
Yeah.
So, I respect where that comes from, but it's not a meaningful tool for me. But yeah, this kind of came out, kind of arose, was introduced at this conference at this time. So I think that pain scale is like an insidious big pharma thing.
It's almost like the commercials that they say where they tell you to like diagnose your own symptoms and then go tell your doctor that you want this medication.
Right. Yeah.
Right.
Wow. So I don't know. Yeah. I don't know if they're OxyContin chewables for the kids. I'm not sure. So so Big Pharma then, as the whole opioid crisis plays out?
Wait a minute, Paul. There's fentanyl lollipops. There's fentanyl lollipops for kids that they get before surgery.
Shut up! No way, really?
No, it's a thing, and it's actually helpful.
I'm sorry, did you just say fentanyl lollipops?
Fentanyl lollipops.
Oh my God!
Yeah, they exist. Yeah.
Wow. Oh my
anyway.
God. Oh, well.
Sorry.
No, that's okay. So I mean, just as I know we're going to get into just costs and things like that as well, but as the opioid crisis has played out, and here we are in 2021, we've got RX Safe Del Norte, we've got Narcan right here in the house. Things have changed. How has that played out? Do you any sort of a concept of how that's played out in Del Norte and Humboldt, just numbers wise, and the impact of the opioid crisis here locally?
Yeah, it's super hard to get to prescribe opioids for chronic pain right now. It goes through levels of government requirements and reporting. So if I was gonna like refill a prescription for somebody's morphine or OxyContin, I have a special app on my phone that has a random number generator, so that when I have to plug it into the computer, so the computer has a secure way of identifying that it's me.
Okay.
That's prescribing it. And then oftentimes I'll get called, especially from the guys at Walmart who are super conscientious. And they'll say, what are you treating here, and how long do you anticipate him being on this drug, and why are you giving 30? And so you have to kind of go through a justification of what you're doing. And internally in the clinics, there's a group of providers that meets, I think, about once a month, and they present the cases, and they talk about how you get people off these meds.
Wow.
And what other non-opioid ways should you maximize to treat their pain? Because when a patient says they want their pain treated, they almost always mean they want opioids or hydrocodone or sometimes codeine, depending on the situation, or tramadol, which is another whole story. But and what I'm thinking of is, I could give them a shot of Toradol, and then they, could ice, and I'm going to give them the stretching handout, and maybe we should get them the physical therapy, and I'm wondering if a lidocaine patch. So what I'm doing is I'm building a house with many tools, so I'm giving them as many resources as possible. And if that doesn't include opioids, then oftentimes the feedback I get is, you're not doing anything for my pain, and I'm like, well, I just did 15 things for your pain.
Right.
Like sometimes the best thing I can do is diagnose it. So then we can solve the problem completely. So there's a huge disconnect, I think, in treating people's pain. But going back to this particular meeting that happens monthly is, all these people bring all the ideas that they have to solve this particular person's pain control issue. And a lot of them are developing, and kind of like I read this article about, and a lot of them are, did you remember to try Neurontin, or did you, how did they respond to low-dose antidepressants, and maybe you should work on their sleep. and that would help their pain. Stuff like that. It's really comprehensive and super helpful.
Now, under whose auspices do these meetings occur? Is it?
They're at the community clinic level, so I attend the one at UHS, but I think there's one that probably goes on at the Open Door too.
Is this just a regional thing? Is this the case? Growing across the country?
Yeah, I imagine it happens in other community clinic systems. I think it probably doesn't happen in a single provider office like Dr. Blundell's because, he's a single provider office.
Right.
So, Lynn, I'm sorry, I didn't mean to interrupt. Before we go too far down the track, I'd like to go back to something that you said. So I understand. So, if you're going to prescribe, some sort of opiate narcotic medication, you go through this process. Then you get a call back from the pharmacy. I understand the logic of utilizing the expertise of the pharmacist in all of this. I guess what I'm a little bit confused about is like having the Walmart Corporation somehow or another be the arbiter of.
I don't. No. I'm going to jump in and let me and correct me if I'm wrong. I'm sorry. My assumption is that because we all know the pharmacist at Walmart is a very, very good guy and very much into the community. It would seem like that it's more of his call and not like a corporate call. I think it's more just the local pharmacist making a call to do
Thank you for clarifying that.
I have to justify my use. He has to justify his filling of the prescription, but he's also. There's two of them there, and the one that I get most of the calls back from is super intelligent biochemical whiz that makes my practice better. But
concerned. He's concerned for the people who come into the pharmacy.
Right.
And I've met him as well, and I agree with all of that.
Prescriptions that he fills. He also has to tick some boxes off too, like I do.
Right.
So it's not like Walmart is controlling it. It's like those guys just seem to reach out more, and they, their community concern is like paramount.
Yeah.
So, super guys, but.
All right. So I have a question. I mean, before I know we're talking about costs and such and things like that. It's interesting you breaking down the mechanism of how you've got people looking over your shoulder when there's a prescription. Now, is that, and that's sort of why I was asking about whether this was a regional thing. Is this just a local Walmart specific thing, or is this something that is a sort of a more widespread reaction to the opioid crisis across the country? This sort of oversight.
Probably every layer of bureaucracy. So like. There's me prescribing, there's UHS standards, there's, let's say if somebody happens to have partnership, there's partnership standards, if somebody happens to Medicare standards, if somebody happens to get their medicine at Walmart, in California, or whether they go to Fred Meyer's in Oregon. I mean, there's layers of,
right.
watchdogs now, and there weren't.
What's the relationship then? What's the feeling in the provider sphere, which is I don't know if you coined that phrase or not, but that's really cool. I like that. Between, but you'll take credit for that. Between like Purdue, the Sackler family, Big Pharma in general, and the provider sphere. Is there? Has there been a break? Is there like a lack of trust now? Oh,
super.
Okay.
Super. And I can talk about tramadol as kind of an indicator of that. So are you guys familiar with tramadol?
Only that it's a funny name.
I've got a bottle of it in my van.
Okay, there you go.
Oh, better not say that on the radio. So Ultram is the brand name, and tramadol is the generic name. And when it first came out, then we were... that was kind of as the opioid thing was being seen as a huge problem. And I think medicine was looking for an alternative. And this was marketed as a non-opioid, non-narcotic drug.
Right.
Okay. And we were like, great. And then we started prescribing it for people, and it immediately started causing problems. And I remember with walk-in, a lot of people who were in the recovery, the individual patients who were in recovery would go into the room and they'd say, look, my teeth hurts, I need some pain control. I heard that tramadol, or at that time they were calling it Ultram, I hear that Ultram's non-narcotic. And so initially we were like, yeah, sure, I'll give you that. And then it started causing dysfunction. It became apparent that people had the same reaction to the drug, the same reaction to the absence of the drug, the same dysfunctional selling it on the street kind of thing was happening. And still, you still have people come in who are in recovery who will claim that it's non-narcotic, and so I should give them a lot of it. But so that I think was intentional. I think Big Pharma, quote unquote, whatever organization makes it, I'm not even certain, intentionally marketed as not an addictive drug, and they absolutely knew it was.
Wow.
And they were actually giving it here, to try and keep people's use of hydrocodone down.
Mm-hmm.
So because there's no Tylenol in it, it doesn't really add to Tylenol toxicity concerns. And so people were actually taking 2 opioids at the same time because we weren't really told what the drug was.
Wow.
Yeah. So they were doing that too.
Well, go ahead. I'm sorry.
Go ahead.
Well, it's reassuring that there's been a response, at least in the provider sphere, and I'm going to try to say that word as often as possible, the provider sphere, that it's that there's like this the healthy skepticism now as to the motivations behind Big Pharma and just accepting things at face value.
It's super, but patients are really angry at us about this.
Well, there's that.
Yeah, there's a surprising amount of acceptance because the individual patient perceives that, it was somebody else who was abusing it, and now it's been taken away from everybody.
Mm-hmm.
But there's also, there's kind of a defeatism and an inability to recognize other pain control measures as legitimate. So they're kind of mourning the loss of it, but I think their brain is telling them to do that. Those little mu receptors are like, no, really, the only thing that's going to help you is hydrocodone.
Right, you got that problematic, addictive voice, addiction voice talking. Wow.
Well, but it's a change in the way people who have been on it experience pain, and they're going to experience pain in a worse way for the rest of their lives, and that. I am really sorry about. I think that's like a horrific thing that nobody's talking about, really. So if that person, let's say a person has low back pain, let's say they get put on OxyContin, the long-acting, let's say they're on it for like 6 years or, a certain number of years, and then they get tapered down, and then it's like, they stub their toe, it hurts more than it would have before.
Right.
They get bone cancer. That's horrific. That is horrific.
Wow.
Yeah, and that's where I think the Sackler family is, and anybody who is involved in pushing this drug, that's what they're going to have to explain to God someday. Everything that goes along with pain med addiction is horrible, but that I think might be the worst for me as a provider.
Yeah. That you're out of balance, and you are out of balance for the rest of your life because you've been hardwired differently because of this.
Right.
Wow.
And what if you had like some little old lady who has terrible osteoarthritis, and you put her on those meds, and it made her life like way more functional and stuff. And I feel like we kind of led people to slaughter, it's really sad.
Is there a way with opioids? This is kind of anecdotal, what I've heard just about illicit opiates and heroin, things like that. Is there a way with opioids if dosages are controlled and it's prescribed for you, could you be long-term maintenance and be a functional human being on opioids?
Yeah, so they kind of do that in Denmark a little bit. So yeah, some people can, some people will never be able to. But
does it depend on the individual like that reacting to?
Yeah, it kind of depends on the structure around them and their pain issue and stuff. There's a lot of kind of individual things. But in Denmark in general, you can not anymore, but you used to be able to get like anything you wanted legitimately from a physician. and there were like no boundaries.
Mm-hmm.
And what the studies told us is that people who had unlimited access to stuff didn't really do very well.
Yeah.
First of all, they habituated to it, so they needed more and more and more until they were at the point where they stopped breathing.
Right.
And their pain never really. So at a certain point, you don't really have a pain problem anymore. You have an absence of the medication problem.
Yeah, exactly. Wow.
Right. So, and it's really hard for people to see that. Plus, I think a lot of people use opioids at some points too for pain of the soul, and that's really, really hard to identify correctly, and also talk about it without people getting super angry because they feel like you're being judgy.
Right.
And a lot of people are. A lot of providers do get judgy, but I don't know. It's a big, complex problem. But Big Pharma, they brought us this.
Well, all right. We are coming up on. We're just about at a half an hour right here for this week's show. Are there more? Is there more things that you wanted to get in? I know we had.
There's a lot more things.
Do you want to do a part 2?
Why don't we do a part 2? That makes sense.
Okay. All right. We'll pick this up. I want to talk about the costs. That's something that we wanted to talk about as well. And then what other things do we need to address?
Orphan drugs. How Big Pharma manipulates orphan drugs and why that's so awful. How formularies and prior auths control what you can get. Why the pharmacies? I'm going to include the pharmacies in here, and I'm not talking about any particular pharmacy.
Yes, you named a particular pharmacy here in the email.
Yeah, and I thought maybe I shouldn't, but
Okay.
There are not any really locally controlled pharmacies anymore. There's barely any. There's 2 in Humboldt County, that maybe 3.
That's something Mike asked yesterday, if we still have mom and pop pharmacies, or had they gone the way of the mom and pop gas station?
Right, they have, and how that affects things like holiday coverage. I mean, this affects how you get meds in Del Norte County. This is very local.
Okay.
So.
All right. Well, we'll pick this up. This has been really informative. I want to hear more. There's almost like a mythical sort of thing happening in my mind around this meeting. This meeting in 2005 or something that sort of changed the space of the provider sphere here in Del Norte and Humboldt, and that's sort of being the ground zero from which everything else proceeded. That's wow. Well, if you hear of any other meeting like that, let us know. I'd like to be at the next one.
If I'm ever sitting in a meeting and wondering why the hell I'm there.
All right, that sounds good. PA Lynn Szabo, thank you very much for this conversation. I look forward to next week's Health Matters, where we pick up Big Pharma in Humboldt and Del Norte, Part 2. Thank you, Lynn.
All righty, thanks. Bye.
Of all the radio stations that tell you they love you,